see you in a bit, sir. First off, I'm sorry if there wasn't very good communication. Did you understand what the plan was when you were coming in today, or did we sort of surprise you?
Oh, I was just a little surprised, you know.
Okay. So,
That's not totally your fault.
okay.
No.
Okay. Did Dr. Pedersen speak with you all on Friday?
No.
No.
Okay. So had you heard anything about the scan results
No.
or
No.
anything? Okay. I very much apologize for all of that.
Oh, okay.
I was off Friday and
Okay.
I had some texts with Aaron and I thought everybody was on the same page.
No, we've been in the wait mode.
Okay, and okay. Well, I'm very sorry that we
That's
haven't
okay.
spoken. So, unfortunately, the scan confirmed what we were concerned about. Those areas that light up do look like a tumor, and that was originally what we thought we were looking at when we looked at the scan. Obviously, you and I, when we first spoke about it, I all but said that this is tumor coming back. I think what fooled us, by the way, I should be sitting down, but thank you. What surprised Dr. Pedersen in particular when he saw you was how well you looked, because we're looking at a scan that looks like there's enough of a tumor there that it ought to be causing some trouble, and yet you were doing great. If anything, your vision had gotten better.
That week it had.
And then now I understand the vision is getting worse again. Is it the double vision again? Thank you, Amanda. Or is it blurry, or is it all of the above, or
It's double vision.
the same as before, basically?
No.
Or
Well, my eyes used to see this way. With
Yeah.
This eye was pointed down, and then the eye started correcting last week.
okay,
Everything was cool.
It was about the week the 13th.
okay.
Started correcting, and now since when we last saw you, it's overcorrecting. So
It's
basically, this
Overcorrected, got it.
yeah.
Got it.
Didn't know you could do that.
Yeah. Well, the nature of the scan last Friday, and you and I never talked about this, is that you can actually use an MRI machine in a completely different way. When we're used to thinking of it in terms of taking pictures. So here's what a slice of your brain looks like. You can actually use the MRI machine to look at a specific area within a scan and sort of interrogate that area to get information about, chemically what is going on in that specific area of the brain. And there are certain patterns of proteins that suggest tumor versus non-tumor. That was the scan that was done on Thursday, and once again, I truly apologize. I figured by Friday you would have heard from Dr. Pedersen or heard from somebody, and so that was a failure of communication on our part. And I realize I'm dropping a bombshell. I don't mean to sound callous, but hopefully it's not a completely unexpected bombshell. I mean, when we first talked about this a week and a half ago, we sort of thought that this is where we were going to end up. Especially with your symptoms evolving too. I hope this doesn't come as a huge, horrible surprise. In terms of the treatment, maybe we haven't been very clear about what the plan is. The type of treatment Dr. Pedersen wants to give you is called radiosurgery. I know he walked you through it. It's basically a way of giving radiation in several big doses as opposed to a whole lot of little doses. Relatively recently, people have begun to look at combining that treatment with a drug that we give here in our clinic called Avastin. Avastin is not a chemotherapy drug in the traditional sense of the word. It works by a completely different mechanism, and I think we might have talked about this before, I can't recall. Avastin works primarily by attacking the blood vessels that feed a tumor. So if you think about it, in order for tissue to grow, in order for tissue to sort of have energy and survive, it needs blood. Tumors that grow basically create new blood vessels as they grow, and the Avastin attacks those blood vessels. Anyway, that medicine has been around, and we have used it in different ways to treat different tumors for probably close to 15 years now, 12 to 15 years. What Dr. Pedersen would like to do is use that as a prelude to the radiation. And there are good data to show that the combination of the Avastin with radiation is one of the more effective ways of treating your tumor. And on top of all that, Dr. Pedersen feels like this is potentially a way to prevent things from temporarily getting worse when they do start the radiation. if they were to dive in with radiation right now, it might actually cause some swelling that would make your symptoms worse. Giving the Avastin first to be followed by the radiation later is the program that we would like to propose.
So, how long will the Avastin before the
2 weeks.
2 weeks? Okay.
So Avastin is actually given every 2 weeks, and I'll double check with Dr. Pedersen exactly how he wants to time this, but what we were talking about was just simply giving you a dose of Avastin here today.
Mm-hmm.
Otherwise, no plans for treatment for 2 weeks. I don't know if he wants us to give the second dose on that next Monday, the 11th, and then do radiation or do radiation and then the Avastin. I think we need to work out the logistics of that. I think he may also want to put you on steroids very briefly when he restarts the radiation. So he and I need to kind of clarify the specifics of what's going to happen. But here today, we wanted to give you your first dose of the Avastin.
Yeah.
This does not cause the side effects that you think of with chemotherapy. It's not going to make your hair fall out.
Try it.
I mean, it's okay. You can give me whatever the hell you want to fix
I was
this
just
thing.
picking his legs, wondering
I
how
mean-
much longer he had hair legs.
Give me whatever.
It can affect the blood counts, but usually not as dramatically as chemotherapy does. It can cause nausea, but typically not as dramatically as chemotherapy does.
Okay.
We sometimes pre-medicate people with Tylenol and Benadryl, but in many cases you don't even need that. In fact, most of the protocols say just give the medicine, and if somebody has a fever, if somebody has itching, if somebody has any kind of a reaction to the Avastin, then you can pre-medicate them. It's a medicine that you can have an allergic reaction to, and so we need to watch for that, and that might manifest as shortness of breath or increased heart rate, feeling lightheaded, that kind of a thing. But a lot of people come in, get their Avastin. We have a little girl who's been on it for her brain tumor for 8 or 9 months now. She comes in every 2 weeks, plops down, gets her Avastin, says see you later. Her mom does tell me she's usually tired for a day or two afterwards. But in terms of changing her blood counts, having any other effects that you can see that are obvious, it's had basically no side effects. Now, like with every drug we give, we have one of those wonderful consent forms that lists all the horrible side effects that might happen, and I do have something I wanted you to look over. But the plan today was to start an IV, run the Avastin. I can give you Tylenol and Benadryl beforehand. I'm absolutely fine doing that. It might head off a little bit of a reaction. And those are such mild medicines. But I'm hoping that today is not very exciting.
I'm sorry, what?
I'm
Not
hoping that
exciting.
today is not very
It's kind of
exciting.
dull. We just, yeah.
I have trouble with grammar. But so we're dealing with 2 tumors here?
Yes, and we can show you the pictures again if you'd like. The larger one is in the brainstem. It's so. If this is the top of your brainstem, the original tumor was a little bit to the left side and basically sitting right here. The new tumor is more within the brainstem. It's slightly lower, and that's the larger one. And then there's a tiny little spot that's actually north of where the original tumor was. But they're both in the same general area as your original tumor, which is how this type of tumor typically can come back. It's not one that we expect to have suddenly show up, in the far corner of your brain or down your spinal cord. I hate to say it, that can happen, but it doesn't usually happen.
But the one further north is not so much of a concern.
Correct.
Okay.
But I think while we're in there, and while Dr. Pedersen is making plans to do radiosurgery, I think he might as well go for both of those spots, and I believe that that's his plan.
Okay. Is there any way we could bring the radiosurgery to 1.5 week
You just-
after starting?
I'll
this?
have to ask him. You
I
just
honestly-
want to kind of get the show on the road.
No. In all honesty, I think I'm going to be in the hospital under the next 2 weeks.
Okay.
From how much my vision has changed.
Well,
I still bump into things on walls. I don't know if that's associated with
And,
this.
and the Avastin all by itself is potentially going to help. So the little girl that I mentioned with a different type of tumor, but actually similar to your tumor, is not getting radiation. She's not getting chemotherapy. She's simply getting Avastin. She was having visual problems that have significantly improved just from the Avastin. So all by itself, Avastin is a form of therapy. But I do hear your question. I mean, when we sort of tell you you've got a tumor, you need radiation, and you're having symptoms, and then we say, oh, the radiation will start in 2 weeks, you're looking at us like, wait a minute. So let me talk with Dr. Patterson about that.
Yeah, and this isn't like a hospice situation, is it? Like,
No.
No.
Okay.
Totally.
That people do get cured from this sort of thing.
Yes. But I have to, no, you have a type